Hello, this is Greg Modrell. I'm a faculty member at the University of Texas Southwestern Medical Center in Dallas. And I'm going to speak today on lower extremity arterial physiologic testing. Before I begin, I'd like to thank several people who contributed to this presentation, especially Ms. Lynn Labuda, who's Director of the Vascular Laboratory at the University of Texas Southwestern Medical Center, Christopher Busey, who's Director of the Cardiovascular Laboratories at the University of Wisconsin Hospitals, and Jill Thordenson, who is Director of the Vascular Laboratory at the USC Keck School of Medicine in Los Angeles. I have no relevant conflicts of interest to disclose. I will note that this is a volunteer production on behalf of the Association for Program Directors in Vascular Surgery, so the materials herein are not for sale. All material taken from outside sources are appropriately acknowledged, as you'll see noted on individual slides. So today we're going to speak about several non-invasive physiologic tests performed on the lower extremities. Those include Doppler waveforms, ankle brachial indices, both resting and exercise ABIs, toe pressures, segmental and Doppler waveforms, pulse volume recordings, and transcutaneous oxygen readings. We're going to speak briefly about the clinical utility and pitfalls of each test and provide a series of clinical examples to reinforce some of the lessons that we'll learn. So the first place to begin is the foundation of Doppler waveforms. Now, for the purposes of this discussion, we're not going to go into the Doppler formula or Doppler shifts, but we're going to briefly review the different waveforms that one would encounter with Doppler waveform tracings. So Doppler tracing is actually a velocity over time tracing, as you can see depicted in each of the three examples to the left side of the screen. A triphasic waveform has, as you can see on the screen here, a positive inflection during systole, and then a early diastolic reversal flow, followed by a late diastolic positive flow. And so hence the term triphasic. As an artery becomes diseased or stiffened with atherosclerosis, you see the loss of the late diastolic forward flow. Therefore, this is called biphasic. Now, the problem in distinguishing between triphasic and biphasic waveforms is that not everyone will assign the term triphasic or biphasic to the same waveforms, which creates confusion. So a recent consensus statement decided it was probably simpler just to label these as multiphasic waveforms as opposed to monophasic. The distinction meaning that triphasic and biphasic waveforms have multiple phases and represent relatively normal or minimally diseased arteries, whereas monophasic waveforms are quite different. Now, as you can see from the tracing at the bottom left panel, the monophasic waveform is first characterized by a slower upstroke, followed by a more rounded peak and a slow decline in velocities, with all of the flow being forward flow and much of it being during diastole. This monophasic waveform is indicative of severe disease. So as depicted on the right side of the screen, this is truly a continuum from normal or minimal disease to severe disease, and being able to recognize multiphasic waveforms from monophasic waveforms is critical for determining the level of appropriate disease. Now, Doppler waveforms are relative qualitative assessments of the arteries at those levels, but more quantitative are ankle brachial indices, or ABIs. An ABI is performed as depicted in the left screen with blood pressure cuffs on both upper extremities and both lower extremities, with the blood pressure cuffs in the lower extremities being placed at the ankles. You then use a Doppler, continuous wave Doppler, to listen for flow at the arteries in the arms at the brachial arteries and at the ankles at the dorsalis and posterior tibialis arteries. Now, these can be done at the bedside by an individual with simple tools such as blood pressure cuffs and a handheld continuous wave Doppler, or can be performed in the vascular laboratory with more sophisticated equipment that produce tracings that are more accurately depict the level of the pressures. And basically, by convention, the ankle brachial index is the highest ankle pressure, whether it's the DP or the PT, over the highest brachial artery pressure. And there have been alternatives proposed, but this is probably the most widely accepted utilization of the ankle brachial index. Now, interpretation of the ankle brachial index is listed below. The normal ankle brachial index should be somewhere between 0.9 and 1.2, perhaps as high as 1.3. When it's less than 0.9, this suggests that there may be some arterial occlusive disease. When it's over 1.2 or 1.3, this suggests that the artery is severely calcified and therefore no longer reliable and likely has significant atherosclerosis, with medial calcinosis causing stiffening of the arteries and causing the arteries to collapse at pressures higher than the actual perfusion pressure. Therefore, the pressures measured are no longer reliable. When the ankle brachial index drops below 0.9, you can have claudication. Now, what's interesting is that most patients won't experience claudication at an ABI of 0.85, for instance. And the reason for this is that those patients would need to walk perhaps a mile or more to develop calf or thigh pain and claudication symptoms. And as we all know, many older people, for a variety of different reasons, ranging from degenerative joint disease to cardiopulmonary problems, don't walk that far. And so they actually don't know whether they would have claudication with an ankle brachial index of 0.85. As the ankle brachial index diminishes further, though, it's more likely that the patient will experience claudication at shorter distances. Now, typically, ischemic rest pain occurs at ankle brachial indices of less than 0.5, and ischemic tissue loss, such as non-healing ulcers or gangrene, typically occur when the ankle brachial index gets well below 0.5. Now, it's important to remember that these ranges are all approximations. There are many patients walking around with an ankle brachial index of 0.3 with no tissue loss or ischemic rest pain. By the same token, some patients can have wounds that fail to heal with an ankle brachial index of 0.6. So these are simply a guideline and should be interpreted in the context of the patient and all of the other data. Now, there are some caveats that are critical to understanding and interpreting ankle brachial indices. First of all, as I noted before, ankle brachial indices may be artifactually elevated by calcified ankle arteries. And this is particularly prevalent in diabetics or patients with renal failure. Clinical clues that the ankle brachial index is unreliable are ankle brachial indices that are high, in other words, greater than 1.2 or 1.3, or when you have a normal or near normal ankle brachial index with monophasic waveforms at the ankle arteries, namely the dorsalis pedis and posterior tibial arteries. And this is an example of that. You see below that this patient has an ankle brachial index of 0.3, but in fact there are monophasic waveforms at the ankle. So this is obviously artifactually elevated, unreliable, and the patient has severe arterial occlusive disease. Same is true on the other side. So the solution to this problem is to use toe pressures as a relative index of perfusion of the foot. Now, I will note that this phenomenon is really what explains why most of the clinical trials that were determined prediction of healing of toe and forefoot wounds were based on toe pressures, not ankle brachial indices, because in many patients, ankle brachial indices are simply not reliable, especially in patients who are diabetics or have renal failure. So a little bit about toe pressures. Toe pressures are obtained with a small digital cuff and are measured using tracings derived from photoplethysmography, as you can see encircled in the bottom left side of the picture. Most commonly in most labs that I've worked in, the great toe pressure is measured. But you can actually, if you had, say, for instance, gangrene of the great toe, you might measure the toe pressure in the second toe or the third toe. It's basically can be measured in any toe if the cuff is able to fit on that toe and remain in place. And this is a good clinical example of a patient who has non-compressible posterior tibial and dorsalis pedis arteries, has a PPG waveform at the toe, showing a toe pressure of 160 on the right, 146 on the left, and excellent toe brachial indices. So in fact, in spite of the fact this patient has basically lead pipe arteries, the perfusion of the foot is quite good. So this is how toe pressures can help you in interpreting the numbers that you see from the ankle brachial index when those arteries are calcified at the ankle. And the reason why toe pressures are useful is that toe digital arteries in the toes are typically not calcified and not subject to the same problems with medial calcinosis and inability to collapse at an appropriate pressure reflective of perfusion of that toe. Now, what is a normal toe pressure? Well, there's a lot more variability. So we typically say that any toe pressure that produces a toe brachial index of greater than 0.6 is normal. It should be understood, however, there's some variability in toe pressures from test to test. The same toe may have different toe pressures at different times due to variations in temperature in the room or volume status, other variables. In the clinical trials that were done several years ago, the most commonly used thresholds to predict wound healing were toe pressures greater than 40 millimeters of mercury in non-diabetics and greater than 50 in diabetics. And in this table, this shows basically how the toe brachial index varies in parallel to the ankle brachial index. If you have a very calcified vessel, you may have an ankle brachial index that's greater than 1.3 or 1.4, but the toe brachial index may be unaffected, as you saw in the previous example. Whereas in a normal vessel that collapses like it should at an appropriate pressure, and you get an ankle brachial index between 0.9 and 1.3 or 1.4, you'd see a toe brachial index greater than 0.6. But as you get progressive PAD, you'll see a diminishing toe pressure and therefore diminishing toe brachial index, as indicated in these examples in the bottom three panels. So this is putting it all together here. This is a tracing from our hospital in which we use segmental pressures and segmental Doppler waveforms to assess for atherosclerotic occlusive disease at various levels. With these segmental pressures at the high thigh, low thigh, calf, ankle, and digit, you can infer the level of the anatomic disease. Specifically at the high thigh, the normal high thigh brachial index should be 0.8 to 1.2, and specifically between levels, the gradient should be less than 20 millimeters of mercury. So if you see, for instance, a drop from the low thigh to the calf of 30 or 40 millimeters of mercury, this might be indicative of occlusive disease in the popliteal or proximal tibial arteries. And I should say, I'm sorry, from the popliteal level to the ankle level. Now, it's very important to understand that once you have an abnormal Doppler tracing at a given level, it's not going to fully recover distal to that. So for instance, if you have significant aortoiliac occlusive disease, you may have abnormal Doppler tracings at the thigh that would never normalize as you go further down the leg. And in fact, really what you'd be looking for there is a change in pressure, further diminution of the pressure, or a change in the quality of the waveforms as you went further down the leg. And we have some nice clinical examples to show you how this can be utilized to determine the level of occlusive disease. Now, pulse volume recordings are different than ankle brachial indices. They're basically obtained with air plethysmography, so not the same as toe pressures, which were photoplethysmography. And these are basically air bladders placed at different levels up and down the leg to determine the relative change in volume, which is reflective of the flow at that level. And so a normal PVR tracing looks like this. Should be a rapid upstroke, a sharp peak, a dichrotic notch, and then a concavity in the downslope. Now the advantage of PVRs, and I apologize for the typographical error at the top of the screen, the advantage of PVRs is that it assesses total perfusion at each level via the named arteries and the collaterals. And this contrasts with ankle brachial index that only measures perfusion at 2 points, at the ankle, the DP and the PT arteries. Now, this is particularly helpful when predicting healing of wounds, surgical or otherwise, because pulsatility at the level of the tissue loss is highly predictive of a increased probability of wound healing. And our podiatrists, for instance, are loath to perform a toe amputation or a transmetatarsal amputation without pulsatile waveforms at the transmetatarsal level. And I'm going to give some examples of this in a few minutes. The disadvantage of PVRs is that these are qualitative, not quantitative data. PVRs are qualitative, whereas ABIs are quantitative. But they still each have their roles and provide complementary information. And the examples we provide later will show that. This is an abnormal PVR tracing, so there's a slower rise time to the peak, a flat or rounded peak, an absent dichrotic notch, and a concavity down. And the absent dichrotic notch is the first thing to go as an artery becomes abnormal. But what you'll see later, and examples later, as the disease progresses, you'll see quite a bit of flattening or rounding of the peaks, and the magnitude of the peak or will go down considerably as well. And you can see this oftentimes as you move down the leg with PVR tracings at different levels when the patient has arterial-occlusive disease. Now, transcutaneous oxygen readings are used in many laboratories to try to predict healing. Now, there are some significant pitfalls that are worth mentioning, and you have to understand before they can be interpreted. They're generally less reliable with significant edema or cellulitis. And with our patients with cardiovascular disease, these can certainly become problems. As you can see in the table at the bottom, a TCO2 greater than 40 millimeters mercury is suggestive of good healing potential, whereas a TCO2 less than 30 is suggestive of poor healing potential, whereas the gray zone is between 30 and 40 millimeters of mercury. And here's an abnormal example, okay? Actually, let me go back to the previous example. You can see here the right below knee, right anterior foot, left below knee, and left anterior foot are all above 40, so in that normal range. Whereas in the example here, there's an abnormal reading in the left foot with a toe pressure of only, a transcutaneous oxygen measurement of only 12. And there's, in the gray zone, higher up near the ankle, but normal further up the leg. So this would be suggestive of a person who probably could heal, would certainly heal an above knee amputation, probably a below knee amputation, but as we go down to the ankle and the foot, it becomes more dubious whether the patient would be able to heal any wounds or incisions at those levels. So how to put these together? This is the way I tend to look at vascular laboratories. The information is complementary, and very few of these numbers or data can stand on their own too. No single test is perfect. The tests are all complementary and should be used together. So the way I look at a patient is I first go immediately to the ankle brachial index. And then I look, are the waveforms consistent with the ABIs? So let's say you had a patient with a normal ankle brachial index of 1.0, but monophasic waveforms at the ankle. Then they're not consistent, and we know that the ankle brachial index should not be trusted. So if ABI is not consistent with waveforms, then you default to toe pressures. And then then I would also review whether it's normal or abnormal. I would review pressures, Doppler waveforms, and PVRs at all anatomic levels to try to determine if there's any gradient or progressive disease as you go down the leg and at what level that occurs. And if I have an open wound, or I'm planning on creating an open wound with an incision, let's say a transmetatarsal amputation, then I always try to look at all the data that I have available: toe pressures, PVR facility, and transcutaneous oxygen levels if your lab measures them. I will say that I've been at labs that did not measure them, and I've been at labs that did measure the transcutaneous oxygen levels. So not every lab will provide that information. Okay, one last special test, and that's exercise ankle brachial indices before we launch into some examples. The clinical utility of exercise ABIs is discerning claudication from other conditions when the symptoms are equivocal. I think we've all seen a patient comes in with leg pain with ambulation, and the question is it really vasculogenic claudication? Is it neurogenic claudication? Or is it something altogether different? And this is where exercise ABIs can be helpful. And when I was a resident several years ago, it was very interesting to do this test on our own without even the tracings. Oftentimes, patients who had true claudication, their actual ankle brachial indexes were impressive, whereas those patients who had normal ABIs after walking and development of symptoms had no vascular disease. So even without these tracings, this test can be done, and it can be very helpful. If you choose to do a formal exercise ABI test, it should be on a treadmill with a 2 mile per hour speed, 12% grade. I will tell you to note those numbers because they tend to reappear in exams. The test is done for 5 minutes or until symptoms start. You obtain ABIs at baseline, 5 minutes, never 1 to 2 minutes during recovery after symptom onset. A normal response is minimal or no increase in the ABI, and actually initially you may see an increase in the ABI, whereas an abnormal test is a greater than 20% decrease in ABI from baseline. And actually what's particularly instructive in many cases is the duration of recovery. If you have a very slow, prolonged recovery, I think you can rest assured the patient really has claudication, and those are the people who are more likely to have lifestyle limiting claudication. So now some examples. This is a normal exercise ankle brachial index. You'll see this is the brachial pressure in purple, the right ankle in red, the left ankle in green. And what you see is at rest, you see that the pressures here, but with exercise, the brachial pressure actually goes up considerably, and the right ankle pressure also goes up in parallel. The left is a little strange, and it doesn't go up initially, but certainly by 3 minutes goes up. So this would be considered a normal test result, certainly not positive. Whereas in this abnormal test, you see the brachial pressure again in purple, and it goes up and then slowly starts to come down as symptoms came on. And you see that both the right and left ankle pressures go down, and it takes a long time for them to recover to the level of the purple. It took for the right ankle 6 minutes for there to be full recovery of the pressure to the level of the brachial pressure, and 8 minutes in the left ankle pressure to return to the baseline equivalent of the brachial pressure. So this would be an abnormal test result. Okay. Now we're going to go through some examples here, and I'll tell you how I would look at interpret the data as I go through this. So this is I will tell you this is a abnormal test. Okay. So the first thing I do is look at the ankle brachial index. So it's 0.66 on the right and normal 1.06 on the left. I then would look at the pressures up and down the legs. This is high thigh, low thigh, and they look fairly stable. There's not a dramatic decrease. And then the toe pressure is greatly diminished to 25 with a toe brachial index of 0.24 on the right, whereas on the left, the numbers are normal throughout, and you have a very preserved toe pressure with a toe brachial index of 0.71, which, as we said, anything over 0.6 is normal. Okay. Now this is a normal one on both sides with ankle brachial indices that are normal on both sides and toe pressures that are relatively normal. This toe brachial index is 0.56, so it's barely diminished. Not sure what to make of that. This one is, the toe brachial index is 0.63, so this is a normal, okay? So, and these are the pressures. You can see these are triphasic waveforms, okay? So this is the femoral triphasic waveform, one phase, two phase, three phase. And as you go down, you really don't see a lot of change as you go down. The amplitude is a little different, but you don't see much change or deterioration in the quality of the waveform. And you see effectively the same thing on the other side. And so this is the patient we said had preserved toe pressures as well. So if I were looking just at this test, I would say ABI is normal. I don't see a change in pressures, triphasic waveforms throughout. This is a normal test. Same thing on the other side. Now these are PVRs. Now we talked about the dichrotic notch and other components of the PVR waveform. Oftentimes those are a little difficult to see on the tracings. So what you're really looking at especially is sharp upslope, sharp peak, and pulsatility throughout. And what you see is nice pulsatility throughout on the right side, and pretty similar on the left, maybe not quite as high quality at the left thigh, but otherwise very nice. And so this is a normal exam. Okay, now this is an abnormal test. So we're going to go down here, and as I said, I always look at ankle brachial indices first. 0.66 ABI on the right, normal on the left. Now, let's look at the normal one first. Next thing I would do is look at the waveforms at the dorsalis pedis and posterior tibialis artery. Are they high quality waveforms? Do they look triphasic or biphasic? In other words, multiphasic. And in fact, they do. So that's a normal ABI that's reliable. And the toe pressure is 75. And the toe brachial index is 0.71. And as you would expect, there's no diminution in the pressures or the waveforms as you go down the left leg. On the other hand, ankle brachial index at 0.66. We're going to look at our Doppler pressures. Even at the thigh level, they're very abnormal compared to our brachial pressures. High thigh brachial index of 0.59, and it doesn't really decrease below that. But so there's obviously some inflow disease on the right, and in fact you see not at all triphasic. This looks very monophasic, and it stays monophasic throughout. So, and has a toe pressure of 25. So the right side, the ankle brachial index is significantly diminished. It appears that this is mostly iliofemoral disease because it's above the level where our top pressure and top Doppler waveform were obtained. These are the PVRs in the same patient, and sure enough, as we see on the left, very sharp PVRs all the way down, very pulsatile, normal PVRs effectively. On the right, very abnormal. You see the amplitude is less compared to the other side. You see that they're more rounded in their peak and just very different than what we see on the right side. But there's also not a deterioration from top to bottom, so this is consistent with inflow disease. And in fact, this is what the readout from our lab looked like. This is a real patient, de-identified obviously. On the right lower extremity, the ankle brachial index demonstrates evidence of moderate arterial insufficiency at rest. The right great toe pressure indicates that distal perfusion may be inadequate to heal lesions at the level of the toes because there was a toe pressure of 25. Right lower extremity waveform analysis reveals evidence of obstruction at the iliofemoral artery level because it was proximal to our first level of reading. So it means it's either common femoral or iliac or aortic level. It's probably not aortic because the left side looks good. On the left lower extremity, everything was normal. Okay, so this is how you'd put together an abnormal exam, putting all of the information together, ABIs, toe pressures, segmental Doppler waveforms, and PVRs. Another example, a patient who's a 55-year-old male presenting with right calf cramping after a few minutes of walking, and they give you this nice little bit of additional information. History of occluded right popliteal to peroneal artery bypass graft. So we expect something abnormal on the right, don't we? Okay, so let's start with the left side. Multiphasic waveforms at the femoral, popliteal, posterior tibial, and dorsalis pedis levels with nice waveforms at the toe, ankle brachial index 1.27, toe pressure of 87 with a toe brachial index of 0.63. So left side is totally normal, okay? What's interesting on the right is, as we look at this, is the ankle brachial index is 0.68, but there's a triphasic waveform at the femoral, but then it deteriorates as you go down. This is multiphasic at the popliteal, but it's not as clean as the femoral level, so they call this biphasic, and clearly monophasic at the posterior tibial and dorsalis pedis artery arteries at the ankle. And obviously a PPG waveform that's barely pulsatile at the digit with a toe pressure of 41. So this is consistent with, what do we see? Well, there's some superficial femoral artery disease, but there's clearly between the popliteal and the ankle, there's a lot of disease. So it's mostly tibial disease. So this is how you would put this together. These are PVRs, okay? Again, the left side, sharp, nice amplitude, okay? Whereas on this side, you see sharp at the high thigh and the low thigh, but the calf is where it drops. So somewhere between the popliteal artery and the ankle or the calf, there's disease. So probably the proximal tibial arteries. And so this is what you get when you have tibial disease, especially in the proximal tibials in this case, because you have calf waveforms that are very abnormal. Okay, and this is what the report looked like from our laboratory. Ankle brachial index on the right at 0.68 with a digital pressure of toe pressure of 41 millimeters mercury and a toe brachial index of 0.29. Normal on the left, and you see the Doppler waveforms interpreted here, triphasic, biphasic, and then at the ankle, monophasic and monophasic. And the report says, on the right lower extremity, the ankle brachial index demonstrates evidence of moderate arterial insufficiency at rest. The ankle brachial index is 0.8, as opposed to 0.71 in the previous exam. The right toe pressure indicates the distal perfusion may be inadequate to heal lesions at the level of the toes and forefoot. And then it talks about the left side being normal. Okay, another case. We have a patient who has on the left ABI of 0.35, toe pressure of 27, toe brachial index of 0.20. The right side, oh, this is interesting. We have a ABI of 0.64, but we also have one of 1.54. So that's suspect for being calcified, and then we're a toe pressure of 0. And in fact, here's what the PPG tracing looks like on that digit. And just if you had any questions about this being abnormal or not in the dorsalis pedis, you see this extremely monophasic waveform there. So that's a very diseased artery. Now let's go look for segmental changes. Starting on the left, very monophasic as you go down, all the way down, but it doesn't seem to be much change here. So that I would say this is probably inflow disease, iliofemoral disease, okay? And then on the right, it's also the same. It's monophasic at the groin, but higher quality monophasic because there's more amplitude compared to the left. But look at this, superficial femoral artery is absent, then it comes back at the ankle level, at the popliteal, but it's really terrible at the ankle. So this patient has multi-level disease on the right. Certainly inflow, but also superficial femoral artery disease, and probably some tibial disease too because of this waveform down here. So this is multi-level, whereas on the left it looks like it's primarily inflow at the iliofemoral level. Now, what's interesting here is that there's not too much difference in the PVRs from left to right. They're all abnormal, and there seems to be, I guess, at the ankle on the left is where things finally get particularly bad, whereas they were bad from the calf and the ankle on the right. Now, they weren't normal up here, but they really got terrible down at the calf and the ankle. So again, multi-level disease on the right, and mostly inflow disease, and maybe a little bit of distal tibial disease on the left. So this is what our report looks like. You see the ABIs, the toe pressures listed, the interpretation of the Doppler waveforms. Okay, so just to reiterate again, the way I like to interpret non-invasive labs is I begin by looking at the ABIs. Then I ask myself, are the waveforms at the ankle consistent with ankle brachial index? If so, great. If not, then I default to toe pressures. And then I look up and down the leg at the Doppler waveform, at the pressures, the arterial pressures, Doppler waveforms, and the PVRs, determine where the disease is. Is it one level, is it multi-level, or is it no levels? And then if I have a wound at the toes or the forefoot, I look at toe pressures, transcutaneous O2s, PVR, pulsatility for prediction of healing. And again, just to reiterate, no single test is perfect. All of these tests provide complementary information that should be used together. So in summary, ABIs, Doppler waveforms, segmental pressures, and PVRs provide complementary information, need to be used together. To assess the probability of wound healing, use toe pressures, TCPO2 measurements, and PVRs together in concert, and understand the limitations, pitfalls of each test is critical to their interpretation. As we said, ankle brachial index can be confounded by calcified vessels. TCO2s can be confounded by edema or cellulitis. So it's important to understand those things before you put too much emphasis on tests that may not be reliable. And in those cases, you may want to shift using some of the other modalities to put the picture together to make a determination about the extent and the levels of arteriocclusive disease. So thank you again. It's nice to host you with this video conference. If you have any questions, feel free to email me at greg.modrell, M-O-D-R-A-L-L, @utsouthwestern.edu. Thank you very much.